and welcome to another edition of Talks with Interesting People. Today I'm joined by Dr. Shaival Kapadia, a prevention-focused cardiologist here in Richmond, entrepreneur and longtime leader at James River Cardiology. Dr. Kapadia has spent decades caring for patients across the spectrum of heart disease, with an emphasis on early detection and proactive prevention of atherosclerotic cardiovascular disease, otherwise known as heart disease. Today, we get to dig into Dr. Kapadia's decades of education and experience and learn how he is advancing cardiology practices to identify risk earlier and practice preventative cardiology. Thanks so much for joining me here today. I'm really excited to talk with you. So I just always enjoy, tell me kind of what heart healthy practices have you practiced so far today or in the past few days? What are your foundations?
So I'm obsessed with Peloton, and so I'm a runner, as you know, but I've cut back my running to twice a week, and now I do indoor cycling and I do strength training. So I'm on this Peloton challenge for 8 weeks where I do 2 rides a week and 3 strength workouts. So today I did a 45-minute full body strength workout. So I've been doing something every day and then trying to incorporate mobility, stretch, yoga, sort of, because I really need that. As well. So it's been really fun. I try to get that done early in the morning before I get to work because it really sets off the day in a good way.
Yeah, and so that kind of brings up, I'm just preaching more and more because in my area, and I'm sure maybe in your area, but people always want to talk about supplements or what's kind of the newest fad or diet. And I'm like, movement. And
Yeah,
I've really gotten into talking about VO2 max, not for athletes, but as
yeah,
a measure of health and prevention of all causes of mortality. So it's perfect that you just pointed out that like exercise is your foundation.
I know, and it doesn't take very much. I know we'll probably talk more about it, but it just the curve is such that you get just getting off your couch and walking a little bit makes a difference in your outcomes, right? And then the rest of it, there's incremental returns all the way.
Yeah,
So.
that's perfect. Well, I see you in the morning in the cold.
Well, maybe.
Yeah, I know. I haven't been the last cold Saturdays. Yeah, that's awesome. Okay,
Yeah.
so tell me how you got into cardiology, why you picked that as your specialty, and how you ended up in this more advanced area of preventative.
Yeah, no, that's a great question. So, like a typical Indian kid, I was brainwashed from birth to become a physician. In my generation, it was either you be a physician or an engineer. Now the options are much more diverse. But I didn't really make it my own until I started doing research when I was at Johns Hopkins as an undergrad. And when I became an MD and I went to University of Virginia, I was like, okay, what do I do next? And I loved everything, as you would expect. So I initially thought about going down the family practice route, and I really liked the idea of whole person care. And so I eventually went into internal medicine, which is adult medicine, did that for 3 years, thought about oncology, GI, and I landed on cardiology almost serendipitously. And so while I was a medical student at UVA, I was a telemetry tech in my first and second years to make some extra money. But I really took in the rounds on the weekends of the attendings and the fellows and the residents. We're talking about cases in the coronary care unit. So I think that was definitely something that seeped in into my thinking. And then I did some clinical research while I was a resident at VCU. And so that kind of shaped my interest in cardiology. And one of the things that I've really found exciting about this field, one, it's advancing very, very fast, but it's a very rewarding field in the sense that people come in very sick on the one end, heart attacks, that type of thing, and you can make them better very, very quickly. And so the spectrum of heart attacks, heart failure, high blood pressure, all the things really lend themselves to a lot of lifestyle changes. And in addition to the conventional pharmacology and whatnot, but there's a ton of diet lifestyle changes that can really impact that. So as I've been in practice for, just over 30 years or almost 30 years, and I've really found that while I've loved the acute piece in the hospital, I've really been drawn to the early detection prevention space because that's where working upstream really matters, right? Because you can really change the trajectory and the biology of heart disease if we start earlier.
Yeah, and kind of not just survive it, but maybe thrive too.
Thrive, exactly,
Yeah,
exactly.
yeah,
That's exactly the right word.
yeah. May I ask what was your research at VCU?
So I did. It's called preconditioning, ischemic preconditioning. So basically, in a rat heart, we would deprive a heart of blood flow for a period of time and repetitively, and then obviously we'd cause a heart attack. But what we found in that situation is that those repetitive bouts of ischemia or poor blood flow would then condition the heart to tolerate a larger insult. And I furthered that research when I was at Brown in the pig model. And this is something that's really true in, that has applications in cardiac surgery when they do cardioplegia to stop the heart and whatnot. So really exciting stuff. And even after a heart attack, and we used to use clot busters to relieve obstruction, and now we do balloons and stents. But all those things, the body has ways to heal itself and minimize the risk of heart damage. So that was a lot of the work that I did early on.
Well, it's almost kind of like exercise. The heart muscle will adapt. It adapts to the ischemia.
Yeah.
Yeah. Can, in lay people's terms, how could they maybe relate to that in a real world or some a lay person's experience?
So the classic example is someone that is a couch potato and just looking at our Richmond weather over the past couple of weeks, goes out and tries to shovel the snow and the ice in particular, extreme strenuous effort. In that situation, there's no adaptation, there's no conditioning. That's a perfect situation for ripe for a heart attack, and that does happen. In contrast, someone that is conditioned, is exercising regularly, and then when faced with some strenuous effort that is required, can adapt to that situation well because the heart is conditioned. So that's the advantage of conditioning in that circumstance.
So check me, make sure I'm understanding. So when you're doing ischemia in the rat heart, that's actually kind of a bad thing, but it's almost like simulating exercises effects
Yes.
that the heart would then adapt to the lack of blood flow, the lack of oxygen by making, I don't know if it'd be stronger or more mitochondria or something to be able to something.
Yeah, so it could be yes. So there's a short-term benefit. I think a short-term thing that can rely on new blood vessel formation or collaterals or enhanced ATP mitochondria, and then over time there can be genetic changes that can adapt the heart.
Awesome.
Uh,
And then I mean, I just remember my grandmother, she had a heart attack in her 50s and completely changed her life, started hiking 5 to 8 miles a day. And then by the time she needed bypass surgery in her 70s, she'd actually created arteries completely around blockages because of the exercise. So
yes,
yeah,
yes.
yeah,
So
shout out
that's
to exercise.
Yeah, I know it seems to be a running theme here. So I think the
Yeah.
whole VO2 max thing is a real thing. I mean, there's two things that predict longevity in humans. It's VO2 max, the ability of the body, the heart, and the lungs to extract maximum oxygen. And number two, believe it or not, is grip strength. And we think, oh wow, how does that work? Well, it's really a marker for total strength and muscle mass. It's not just about how you can grip, but so those two things predict longevity more so than any other comorbid condition, high blood pressure, diabetes, all important stuff, but VO2 max and grip strength are really up there.
Yeah, I got a handout. I'm working on it over here, and it's all about that. And also comparing it to like because people want to focus on weight, and weight can be important, but it's as a reflection of diet and lifestyle and other things. But it's so often people who have had excess weight, it doesn't come off, but that doesn't mean you aren't reducing all causes of mortality by gaining fitness, improving your VO2, improving strength. So, you know, I always just try to get people who are already living an active lifestyle to like not focus on the weight number. What do you think of that as
Yeah.
a cardiologist?
Yeah, no, I think it's not about the weight. I think it really is about metabolic health, right? And so you could be overweight as such based on our numbers, but be metabolically healthy. But the problem is that probably 80% plus of Americans are metabolically unhealthy. And that applies not to weight, because you can have skinny fat folks too, people that have normal BMI, have insulin resistance, and overweight people that don't have any insulin resistance. So I think it comes down to your metabolic health and inflammation, which we'll get into, that really drives not only cardiovascular disease, but other kinds of disease processes.
Almost all of them.
Yeah.
Probably a shorter list to think of what it isn't, couldn't,
These,
what it wouldn't drive or what it wouldn't benefit to eliminate, yeah, or reduce. Awesome.
yeah.
I'm so excited about that topic lately. So I'm psyched we're already on it.
Yeah.
So let's go straight. Oh, sorry, what were you going to say?
No, no, go ahead. Go ahead, Tressa.
Let's see. I was going to get into, before we get too much farther, talking about atherosclerotic disease and plaques, but can you kind of give us a layperson's description of what is heart disease and what are the different, names that people would understand in the regular vernacular that, that would be associated with that?
Yeah. So most people, when they think of heart disease, equate that to blockages in the heart arteries, the plumbing side, right, of the heart. So I think about the heart as a muscle. It's a pump with its own plumbing and electrical system. And any of these three, can get out of whack. And mostly when we think about heart disease, we're thinking about the plumbing that we develop rust in the pipes or blockages in the arteries. But you can also have problems with the heart muscle being weak or stiff or scarred. You can have problems with the electrical system with slow and fast heart rhythms, arrhythmias. Atrial fibrillation is one of those. But I think for purposes of what we're going to talk about today, we're really talking about the development of buildup of plaque in the heart arteries, which really is a combination of not only cholesterol, but inflammation, right? It's not a pure plumbing problem or a clogged pipe. It's both. It's cholesterol and it's inflammation.
Awesome. So let's go into that then.
Yeah.
So tell me more about how and why an atherosclerotic plaque develops in an artery. Um, and then a follow-up question that will be kind of like the different variables that can influence that, both, inheritance. It doesn't have to be specific genetics, but,
Yeah.
people are just
Yeah.
kind of screwed a little bit. So versus
Well,
a lifestyle. Yeah.
yeah, so I'd like to think, I mean, we have hundreds of thousands of miles of blood vessels, arteries, and veins in our body. And arteries in particular have a coating that I like to think is like Teflon, right? It's a non-stick surface and nothing should stick to it. But something happens in early life, believe it or not, in our 20s, 30s, maybe even younger, where there's damage to the lining called the endothelium. And it can be smoking, high blood pressure, diabetes, other things that we just don't, genetics that we just don't understand. So when you need three things basically to develop plaque in the arteries. You need injury to the endothelium, the lining. You need elevated cholesterol, and you need inflammation. And when you have those three things, then that's the process of atherosclerosis, which is cholesterol buildup in the arteries can happen. And it's not just about cholesterol getting into the lining of the arteries, it's that it gets oxidized and inflamed. And that's the process of atherosclerosis or soft plaque. So already we know from kids that were in the Vietnam and Korean wars that they had evidence of plaque in their arteries, fatty streaks, which is where it starts, and then eventually to other later stage plaque that eventually calcifies. And we'll talk about why that's important a little bit later. But that's kind of the genesis of it. What causes that injury? As I said, a lot of different things, but and we can identify smoking, high blood pressure, diabetes as the top three things that I think about. But there are other things that we just don't know that can do that. So you know cholesterol obviously gets a bad rap, and we cannot live without cholesterol. So the real deal is that life is not possible without cholesterol. Most of our cholesterol is bound up in cell membranes and in steroid hormones like sex hormones, vitamin D, steroids, cortisol, those type of things. And about 10-15% of cholesterol hangs out in the blood. And if you have too much in the wrong kind, that's when trouble can happen. So think about cholesterol. It's like oil and water. It can't float freely in the blood. So the liver smartly packages up cholesterol into these particles called ApoB. And ApoB has certain amounts of cholesterol and triglycerides. And ApoB is the transport vehicle that ships cholesterol out to the various organs. Remember, cholesterol, every organ makes cholesterol. The liver makes the most, and brain makes cholesterol as well. It's full of cholesterol. Um, and so ApoB is a transport vehicle to deliver all these goods to the various organs.
That's fantastic. That kind of leads into, sorry, getting this out of my eye. Um, so I guess I want to try to make conjecture, and you can always stop me because I always
Yeah.
appreciate talking with people, but like, so how do we think that things like, so you pointed out the study in Vietnamese children. Okay, well, that's a fascinating study because usually, to point out, because usually we think about American diet. And so I'm curious both what the factors we might speculate were in those children that led to the damage to the endothelium, and then also not related to that, what about the American diet seems to encourage that?
Yeah. So just a clarification, Tressa, I meant American soldiers in Vietnam and Korean wars.
Thank you. I
So
misheard.
yes,
Excuse me.
yes, yes. So
But still
I,
interesting what we think was involved with that.
yeah, so I think, I hate to say this, but one of the biggest exports of the United States is atherosclerosis.
Yeah.
And I think it's related to post-World War II industrialization of our food
Yep.
and the genesis and the starting of fast food. Prior to that, it was very much a local industry and regional type of thing. But with industrialization, converting these arms factories into food factories um, changed the landscape tremendously. And you just have to look at. I look at my father-in-law's college and high school photos from that time compared to the way kids look now, and it's dramatically different. I mean, weight has gone up tremendously,
Yeah.
over the past number of decades. So I think it's the way we eat. It's fast food, convenient food, processed food. There's just so many things that we can get into that has changed the dynamic of athero, has really created the milieu for cardiovascular disease at this time.
Yeah, I kind of I always jokingly say, look at Soul Train. All the people on Soul Train are quite slim, and I've always kind of preached don't eat anything invented after 1945. Do you listen to I think it was a Freakonomics podcast because I preach that about processed food and because people are of course like what diet, low fat, high fat, Mediterranean, all these things, Atkins, vegetarian, vegan. And I kind of just keep it simple, like Michael Pollan. And, if it was invented
Yes,
after 1945, eat real food, mostly plants.
yes, not a
But
lot.
again, you can stop me, but I want to make a conjecture. Like you were speaking about is it the soldiers then in Vietnam, right?
Yeah, so it was the American soldiers that came to fight in Vietnam.
And so could we either assume that it was, I mean, the main things I think of is either stress or smoking and other toxins. So why do we think
Yes,
that yeah, some combination?
I think so. So I think we didn't talk about stress yet, but that's an important player here that can really change cortisol levels of blood flow, shear stress across the various arteries. So I think it's hard to imagine what those kids went into. And so coming to those countries as soldiers, probably we were starting to see people's diets already change in the United States. And then coupled with the stress of being in wartime, and everything that goes on with that, probably started the process of plaque buildup at that time. Is that would be what I would conjecture, without any proof, but um,
It makes sense. I mean, I know in science and medicine we need to not just make assumptions, but it makes sense, right?
yeah, yeah.
Do
There's
you have,
biological plausibility, I guess.
yeah,
That's
yeah. Do you have any idea what the actual molecular process is to how American processed diets create endothelial damage, create inflammation, oxidative stress? I don't know specific mechanisms. I just am like, inflammatory, oxidative stress, bad. But I don't really couldn't quote how molecularly that works. And yeah.
No, I don't think I have that level of understanding. I just know that, when we look at um, it comes down to, so I think it comes down to simple ingredients, right? And so when we look at the food we eat today, particularly it's processed food, whatnot, and you look at the ingredients, if your grandparents don't recognize any of the ingredients, then it's probably bad for you at that point in time, right? And so I can't imagine. So I think, short chain fatty acids or the trans fat, as we know, the various industrially produced seed oils, partially hydrogenated, and all of those sort of names, they clearly create inflammation. And so I think that I'm way out of my depth to kind of discuss the molecular basis for all that, but I can't help but think that those things play a role.
Yeah, me too. And like you talked about that we export atherosclerotic disease, and I know that this is very clear studies of as industrial food moves into other countries and then vice versa.
Yeah,
Um, those of us who, the generations as they've immigrated into America end up with way higher amounts of diabetes, atherosclerotic disease, higher obesity, all of those things. So yeah, it's pretty well associated.
yeah,
Yeah.
for sure.
So let's get into some of the more diagnostic side of things. I know you like to run a lot of other markers besides just cholesterol. So what are kind of the top markers you like to look at in helping understand a person's risk and heart disease?
Yeah, yeah. So the first step is identification of risk or presence of disease, right? So I like to use a multi-marker approach, as I call it, and an imaging approach. So we'll start with the multi-marker lab approach. And so most people, physicians and laypersons are familiar with the traditional lipid profile, LDL, triglycerides, um, HDL, the usual things. And they're helpful, but they don't tell the whole story. And I can look at a traditional lipid profile, and I know if the triglycerides are over 80, then I'm thinking about insulin resistance. That's sort of my target for treatment, triglycerides less than 80. It doesn't always hold true, but there are other amazing tests around lipoproteins that really. So when we think about lipids, and then we talk about lipoproteins, we have to understand that all this lipids, this fat, this waxy stuff is carried in these different particles called apolipoproteins. And so one is ApoB, which I mentioned earlier, and that basically is much of where LDL, as we think about it, is contained, low density lipoprotein. So ApoB is an important particle or is an important number that we should know. The next one is NMR. So NMR is a way of doing fractionating your cholesterol particles. So you can look at LDLP, which is the number of LDL particles, pretty much synonymous with ApoB. But then you can look at the size of the particles, and you can look at the various other sort of lipoproteins like uh, uh, IDL, which is intermediate density lipoprotein, and VLDL, which is very low density lipoprotein. We won't get into the nuances of that, but just know there are a bunch of these atherogenic particles. And what I mean by that, cholesterol particles that are more prone to cause plaque. And they are all tagged with ApoB, this special lipoprotein. So looking at the size of the LDL particles is also very helpful. The smaller they are, the more triglyceride rich they are, and they tend to be more atherogenic and associated with something we'll talk about maybe sooner or later, insulin resistance, prediabetes, diabetes. And then the larger those particles are, the more benign they are. We call them large fluffy particles. So ApoB, NMR, and then another really important marker that I check once in everybody in their lifetime is lipoprotein little a, or known as LP little a. So this is a genetically inherited lipoprotein particle, and it has its basis in another family of lipoproteins called apo little a. And apo little a basically binds to ApoB and creates this new particle called LP little a, which is very atherogenic. And so it accelerates plaque buildup in the arteries. It's associated with a higher risk of heart attack and stroke. And it 1 in 5 people, like 20% of the American population, has LP little a. It's highly inflammatory, and it's also associated with increased clotting risk as well. So that's the bad news about it. But the good news about LP little a is, um, well, we'll get to it. We don't have all the tools in our toolbox to dramatically reduce LP little a. We can neutralize or mitigate its effects by doing a lot of other things to lower other aspects of cholesterol. So it's a good one to identify risk. So I check it once in everyone. It's highest in African Americans, and then in South Asians, and then everyone else. So an important test to have. And then the fourth one that I check in everyone, at least at baseline, we talked about inflammation, right? And so there's an inflammatory marker, and there are multiple inflammatory markers. But the one that most people hear about is high sensitivity C-reactive protein, or CRP. So it is a very non-specific marker. You could have trauma, infection, um, autoimmune disease, heart disease, any number of things can cause elevation in CRP. But at very low levels, between 1 to 3, can predict long-term, excess cardiovascular risk. So it's a good number to also know.
That's so wonderful. I'm gonna make that its own explanation right there. Um, what about homocysteine? Do you care much?
I do. So there are other things. So conventionally, I there's so much low-hanging fruit, right? There's so many people that have diabetes, pre-diabetes, insulin resistance, that I can really account for a lot of their risk just based on that. But then folks that I see that have heart disease, atherosclerotic disease, that don't have conventional risk factors, then I start to dive a little deeper. I'll check homocysteine. It's a amino acid that can build up in high levels, particularly if they have a genetic tendency. There's a genetic test called MTHFR, and a mutation of that can increase homocysteine in your blood and your urine, and that can also accelerate heart disease risk. Uric acid, a marker of gout, can increase heart is associated with heart disease risk. And then there's another genetic marker that I look at called ApoE genotype, that's associated not with the excess cardiovascular disease, but also risk of cognitive dysfunction or dementia.
And I've at least we've been taught, or I've been taught at some point, that's coming back into my brain, that of course there's no one perfect diet, or at least that's what I've been taught. But people who have the ApoE, especially if they have two versions of it, is it 3, right?
Yes.
Yeah,
4.
4. Excuse me, I always get that messed up.
Yeah.
4.
Yeah.
Do need to have a low saturated fat diet, low cholesterol diet, because they talk about the other ones may actually be okay on more of a paleo, but that one actually needs to be lower. What have you? Does that anything
Yes.
valid? Yeah.
That jives with me. I think it's low saturated fat, low carbs, all those kinds of things that seem to protect. And I tell, most diseases that we have are not monogenic or single gene diseases. I mean, we know cystic fibrosis, sickle cell anemia. There are a bunch of diseases that are identified as one gene, but most diseases are polygenic, and most of cardiovascular disease is polygenic. So just because you have a genetic tendency doesn't mean that you're going to manifest that. And the expression of that is really modulated by diet, lifestyle, environment. So I really emphasize that when I'm going through this testing with folks, even with LP little a.
That's perfect. So, and I talk about multivariate because, Koch's hypothesis with bacterial, like, in the first part of the 20th century, like it was a huge evolution in science and medicine that we could identify disease carriers and or markers. But I feel like in the West, then we've really come that every disease and every symptom has one cause. So I always want to preach multivariate. We got to consider all the things, which
Yeah.
perfectly leads into the next question, because the people I get to see, a lot of them are resistant to taking medications. They may already have at least a reasonably healthy lifestyle. So I'll get people with kind of a high cholesterol and or triglycerides and or an ApoB and or their LP little a, but their cholesterol's okay. What age, what gender, what family history, what lifestyle, like that's why we love being able to send people to you, to be honest, because I'm like, I know there's the ASCVD calculator, but like, so how do you get, okay, a 45-year-old woman versus a 65-year-old man versus their different family predispositions, lifestyle? Like, how do you then decide what their risk is? And, you tell me, but I always go to a calcium score. Anyway, so
Yes. No, no,
Okay.
this is a perfect. So what I love about what I do every day is that it's personalized and precision, right? And so I may be a minority, but I don't practice cookbook medicine, and nor do you. And so I that's otherwise I would have burnt out long time ago. And the fun part of it is getting the story, figuring out all the variables, and then making a personalized sort of plan. And so we talked about the biomarkers, the lab work. The second thing that I sort out is imaging, right? I honestly think, and I may be a heretic in my field, but I think the ASCVD risk calculator is worthless in my mind.
Okay. That's
So,
weird.
maybe they'll kick me out of our specialty organization, but that's okay. I just think it's people need something to hang on to, and I get that, but it misses a lot of folks that are at risk. So I think the biggest thing, the horizon that we're looking at, Tressa, is decades, right? We're looking at, if you're looking at a 30 or 40-year-old person, you're talking about not their 10-year risk of having a heart attack or something. It's like a 20 plus year, right? And the opportunity and the window is sort of early upstream. So that kind of brings me to, if you can get visibility in terms of their risk through lab work, and then you can also take into account their family history. So when I think about family history, I don't think about, their first cousin once removed, or their grandparents, their grandmother that had a heart attack at 84. I really think about the most important things are parents who've had a cardiovascular event before 60, or a sibling, right? A sibling's probably even the closest. And so that's where I kind of limit my sort of genetic piece there. So,
Not
uh,
even grandparents.
well, grandparents too, but I think the strongest evidence, I mean, disease can skip generations for sure, but I think, the problem with our grandparents is we don't really know why they died. Some of them because they died of something, grandma died of something, and we're not sure what happened there. So it's helpful, the story. But again, the age at which it occurred is also really important when I'm thinking about things. So I look at the family history, and then I take a look at imaging, and the best tool that we have in our toolbox today, that's cheap, easy, very low risk, is a CT heart scan or a calcium score. So basically, it's it's about the amount of X-ray radiation equivalent to a mammogram or less, and it's a CT scan looking for calcium deposits in the heart arteries. And so it takes 10 minutes. There's no IV, no dye. Typically, insurance doesn't cover it. It's about $100 to $150 depending on where you go. And you'll either get a zero score or a non-zero score. So a zero score implies, basically tells you don't have any calcium deposits in your arteries. And then a non-zero score, and that can be one to actually several hundred or thousands, because it determines the amount of, basically the computer calculates how much calcium you have in your arteries. And any non-zero number in my mind implies that you've got buildup of plaque. So why is calcium important? So remember we talked earlier that fatty streaks, plaque can start in our 20s, 30s, 40s, and as that plaque heals and it matures over time in the wall of the artery, it calcifies, which is why then we can take advantage and see it on a X-ray, particularly a CT scan. And so calcification really tells us that you have an advanced plaque in your arteries. And so where you have calcified plaque, then we know that you have soft non-calcified plaque. You just can't see it with this test, but we know it's there. And so I use that as sort of my hook between that and the labs to determine the intensity of treatment at that point in time.
That's interesting. You say any non-zero. So, a 10 or a 20, and then so my questions are basically like, yeah, where do you have a cut, not a rough cutoff of when you really consider it to be a problem? And then also a 50-year-old woman with a calcium score of 25 versus a 75-year-old man with a calcium score like 20, 42. Like, how would you figure that differently, maybe? Or at
Yeah, no,
all?
that's great. So there's a difference between diagnosis and prognosis. So the diagnosis, any non-zero number tells me they've got atherosclerotic plaque. So they're, in my mind, they've got CAD or coronary artery disease, even the score is low. From a prognosis perspective, it's pretty clear that once your score is north of 100 and higher, then cardiovascular risk increases, right? Less than 100, more benign prognosis, greater than 100 at a population level, right? That's kind of where we're thinking about this. And then, of course, if someone is 40 and has some plaque in their arteries, boy, that's, they've had this process going on for several decades, versus someone that might be in their 70s and have a low calcium score, and their prognosis might be very different because their plaque burden is fairly low at a later age in life. So that's kind of how I think about it. If someone has a lot of risk factors based on their labs or genetics, and their calcium score is zero, then I use that as I don't necessarily say, hey, you're good to go, don't worry about anything. I think that's still my window of opportunity, depending on how old they are, right? If they're 35, 40 years old and their score is zero, it doesn't mean that they don't have plaque in their arteries. So calcium scores can have a 15%-ish false negative rate. So we know that. And in order, because it's a good resolution CT, but it's not the same resolution as something called a coronary CTA, where you do a CT scan with dye, and now you can illuminate the arteries and look for soft plaque. And that's a very good test, but it's more radiation and can run $1,500 to $1,800, out of pocket. So in that situation, you can be sure of, if you don't have any plaque or calcification, then you can be pretty sure that you don't. So there's that small false negative rate, but that also could be they haven't evolved into calcification at that point. They could still have soft plaque in their 40s. So it's a good baseline. And then I'd say repeat that score in 3 to 5 years, and then we assess risk. But when we get to talk about treatment, then we'll kind of figure out, who do I want to jump on now, and why do I want to jump on them versus maybe delaying treatment in folks.
Yeah, perfect. Let's talk about treatment because, in our people, and I'm thinking of people specifically that I work with, especially like women, maybe women in their 50s who have pretty high lipids. And you see a few of these people I'm talking about who absolutely do not want treatment, who have a low calcium score. Yeah. So of course, talk about kind of your regular population because, the people I'm talking about are maybe not the majority of Americans. But like, so yeah, how do you determine what treatments in different people in different populations? And then we'll dive into statins because people have lots of opinions about those.
Yes. So the foundation of therapy is really diet, lifestyle, exercise, all the things. That's the base of the pyramid. And so, as we said earlier on in our discussion, that metabolic syndrome, insulin resistance is in probably 80% of the American population. Maybe not so much the folks that you see, but at least definitely the folks that I see. And so to me, that's the lowest hanging fruit, is to figure out how can they lose weight, eat better, eat clean. And that's the challenge there, is that some people just want a pill and not do the heavy lifting. But I feel like that's the key, is really starting now. When do I push that versus pulling out a drug? Kind of depends on the individual and their risk level. So, for example, if someone has a low calcium score, has high risk cholesterol profile, um, what I'm going to do is push the diet lifestyle stuff first for at least 6 to 12 months. I'm going to talk about drugs as a something that we can do in parallel. Um, but it's different from the patient that has already had a stent or had a bypass or has had a stroke. Those people already have declared themselves as high risk, and they need treatment like from the get-go. Not everyone that has plaque in their arteries is going to go on to develop a heart attack, and that's the problem. Is we're still not that refined or sophisticated in our predictability, right? And Because everyone that there are a lot of people that have coronary calcification, but most of them will not go on to develop an event. And the challenge for us and the opportunity for us is to figure out who are those higher risk people. Maybe it's getting better inflammatory markers. Maybe it's other biomarkers or other cholesterol markers that we need to kind of sort out. Maybe AI can help us, look at the vulnerable plaque in these CT scans that are more prone to rupture, because ultimately that's what we're worried about. It's not the calcification in the arteries that is the problem. It's the soft, non-calcified plaque, and there's a spectrum of them. But what happens is that when you have the soft plaque that has all this cholesterol gruel in it, the borders of this plaque are composed with smooth muscle, but there's constant, we know that inflammation is part of this, and the shoulders of these plaques can get thinned and eventually erode and rupture. And that's when the cholesterol in the plaque gets exposed to free flowing blood, and the body treats this as an injury and suddenly starts to activate its clotting mechanisms and inflammation mechanisms. And you can go from a nothing plaque to a 90% or 100% plaque in seconds or minutes. So our opportunity is to identify who are the people that are at the highest risk that we want to treat the most aggressively. But until then, we try to treat everyone aggressively.
What are some of the promising either markers, technology? Is there anything on the horizon for being able to identify the higher risk people and the more dangerous plaques?
Yeah, so as I said, CTA, and
Okay.
there's two technologies that with CTA that use AI. One is HeartFlow, that's a company, and there's another one called Clearly, and both of those at least purport to be able to analyze plaque and identify higher risk. The best way is actually if you could go down the barrel of the artery with ultrasound and look at the composition of the plaque that way. But that obviously is not something that is clinically available, and that's fine from a research perspective. So, it's going to be, I think it's ultimately going to be non-invasive imaging that gets better and better, and it's going to be other markers that allow us to identify risk.
Any inflammatory markers or oxidized markers that are promising or just sort of ancillary?
Yeah, so I tend to use in my panel, like I use LabCorp a lot, but I really like Quest. And Quest, bought Cleveland Heart Labs, which I used a lot. Unfortunately, in Virginia, which is mostly Anthem, Quest is not always covered. So for my Medicare patients, I tend to order Quest because it doesn't really matter. But Quest has a really good panel, and so I'll use oxidized LDL, I'll use myeloperoxidase, I'll use Lp(PLA2). So all these different inflammatory markers represent different stages in the plaque life cycle and can predict risk. So yeah, I definitely do them at the baseline, and then I'll go on to pick a select few like MPO, myeloperoxidase, or Lp(PLA2), to follow people over time.
Are there any algorithms or is AI doing anything? Because yeah, I'm just thinking about all the markers we can get, and then age, gender, other family risk factors, lifestyle factors, and crunch that into some sort of risk factor. I mean, I know that right now your brain is the AI, it's the practitioner. But I mean, I'm just thinking about like two, identical patients, maybe like, but some variation as far as I mean, honestly, you keep bringing it up. Let's dive into it. Like identical maybe lipid panels, but one has insulin resistance and one has not. So how would that change the course of your? And it probably wouldn't be identical. That would be tricky, I would think. But humor
No,
that.
no, it's so actually I'm glad you brought that up, Tressa, because 50% of folks that have heart attacks have normal LDLs. I mean, whatever normal means, but you could have, and that's where the shortfall of just traditional lipid testing really is. So you'll see someone with an LDL of 100 milligrams per deciliter and another patient with LDL milligrams per, it was exactly the same, but one of them had a heart attack and one of them didn't. And why is that? So when you break it down, and that goes to the particle size and ApoB, So the person that had the heart attack more than likely has insulin resistance, and they have a ton of small LDL particles. And so these small LDL particles are highly atherogenic, and they can get into lining the arteries, cause plaque, and all of that. And that's very tightly correlated with insulin resistance. So we've been skirting on the surface of insulin resistance, but I think that's really, today, what do we do to think about that? Well, we can look at BMI, waist hip ratio. They're sort of the gross sort of morphologic issues, sort of phenotypes that I would think about. But then when you dive into their blood work, we're just looking at A1C, we're looking at fasting blood sugar, but they're pretty crude, right? We have diabetes as an A1C of greater than 6.4. We have pre-diabetes A1C 5.8 to 6.4. And then everything south of that, is just the whole wastebasket. Thinking about insulin resistance, this process starts very, very early, right? And by the time you're diabetic, you've lost 80% of your islet cell function in your pancreas. So the islet cells make insulin. What happens is that those that are prone to develop insulin resistance, and typically the phenotype of that is someone that has a lot of visceral belly fat. That's kind of how we think about it. And it can happen in skinny folks too when you do CT scans. If they have a lot of, not the superficial fat, so liposuction isn't going to get you any relief or reduce your risk, but it's the deep belly fat that you could see on a CT that creates inflammation, and that makes the tissues resistant to the effects of insulin. Why is insulin important? Well, insulin drives glucose into cells. When we eat carbs, food, insulin goes up, glucose comes into the bloodstream, insulin drives it back into the various cells. If the tissues don't respond to insulin, and this is very crudely speaking, then insulin levels go up over time. The pancreas has to crank out more insulin. So you could start to see that as insulin levels go up, glucose can be normal for decades. Pancreatic function starts to go down, glucose starts to go up. Now we're in prediabetes. And then where diabetes hits, we've lost 80% of that ability to generate insulin. And now your sugars are way high. So the opportunity is to go way upstream and look at those signals of insulin resistance. And we have them with the tools that we have right now. You can look at triglycerides as one index. You can look at your lipoprotein particles, as I said. So the small, dense LDL can be predictive. You can have lots of LDL particles, so that's also a marker of insulin resistance. And when you order an NMR lipo profile at the bottom, you get something called LP-IR, which is lipoprotein insulin resistance index. And that's kind of a weighted average of the various lipoprotein particles that also gives you a clue. So less than 25 is normal. Anything above that, predicts insulin resistance. So there's all these other markers that can tell you. And why is that important, Tressa? It's because this is not about medications. It's about food and exercise, and that's completely reversible in early stage.
Yeah, that's awesome. And so what I'm just thinking about in the people that I get to work with would be much more potentially some proactive in doing lifestyle and diet and exercise. How do you do that in your practice?
Challenging. So I really wish I had the time, and I wish I had the resources to be able to plug someone in to a therapeutic lifestyle change management program, right? If that was covered by insurance and, hey, you're at risk, you've got coronary disease, or you're at high risk for cardiovascular disease, let's figure this out. And how can we move you more cardio, strength training, and start to eat cleaner? And everyone asks me, the patients ask me, what diet do you recommend? Do you have anything written down? And I say, listen, it comes down to food tactics. And my first food tactic is we eat way too much. So number one, cut back your calories, right? We're as modern humans, we have not evolved from our hunter-gatherer selves where we used to forage for food. The idea of 3 meals and snacks is a completely artificial construct, I think. And nutritional science has really hurt us more than helped us over the past few decades. And you just have to look at the saturated fat story that started in the 60s and 70s. probably, and this is probably my conspiracy theory kind of coming through, but you know, all the sugar industry basically suppressed a lot of information. And so we went on this low fat thing, everything became low fat, but then the fattening of America happened over the decades. And so here we are now. Now we're, I use full fat Greek yogurt as sort of a morning sort of breakfast with protein powder, but full fat is fine. It's the trans fat and some kinds of saturated fat, right? Fat is a very nuanced space, and it's hard to make a big declaration around that. I think the problem really is around ultra processed food and sugar. And so, number one is eat less calories. We consume too many calories. Number two, um, avoid junk food, right? That's the processed food, and that's a bucket of everything, snacks, this, that, the other, sodas. Number three, consume more protein, and it can be plant based or it could be animal based protein. But eating clean is sort of my through line here is that the closer you can eat to the ground of its origin, the better it's going to be, right? And even that's challenging because our soil is tainted, and that's a whole other story. But um, so and the fourth thing that I tell is that if you drink alcohol, drink less, right? There is no health benefit of alcohol, zero zilch. The French paradox was probably related to more social connection than anything else, than the alcohol. So those are kind of I don't and then you could talk about intermittent fasting and paleo and keto and carnivore and all these different diets, and maybe there are nuances, and I think that everyone is different, right? Everyone, I was born in the US, but I'm of Indian origin and I grew up in Hong Kong. So I was exposed to various traditions, Ayurveda and Chinese medicine. And so I know, at least from Ayurveda, that everyone's different, right? Everyone's constitution, there's probably three or at least three types. And so not everyone responds in the same way. So you have to kind of figure out what works for you.
That's so brilliantly put. I so appreciate everything you just said. I also preach, I mean, not to go back to exercise again, but human appetites and human biology were built around movement. And so I've read that anthropologically, and I quote this a lot, humans moved about 5 to 9 miles a day on average, which meant, maybe some days you barely moved and other days you did 20 miles.
Yeah.
And so, the fact that a lot of our ancestors drank bread and wine, well, they were moving 20 miles a day, farming all day through the winter. And so, our biologies and our appetites were built around all of that movement. And so I think we want to eat as close to the earth and natural as possible. And also we actually need to adjust our intake based on the fact that we don't move anymore. Like even if you're a relatively healthy, fit person, you're probably not moving 5 to 9 miles a day like your peasant ancestors. So we need maybe less carbohydrates from that. And I'm also a big plant person. Like, let me know your thoughts on this, but I say, this is your plate, half plants, quarter protein, and a quarter, I don't want to vilify carbohydrates. The carbohydrates aren't the issue, or else the Japanese would not be very healthy, right? But like,
Right, right.
yeah, but a quarter of like some kind of carbohydrate that is close to the ground as possible. What do you think of all of that?
Yeah, I love that. I use that. I think about meat as a condiment, and so I think in the same way. I totally agree with the way you architected the plate. That's
We
what I tell my
each
patients.
other. I appreciate it.
Yeah.
Let's dive into medication strategies and give me, just tell me everything you think about statins. There's cardiologists who say, let's put it in the water. And I always remember that the number one cause of death for humans across the planet, across all economies, is heart attacks, heart disease. At least that's what I've been taught and read. So, I can see maybe statins aren't good for some people, but neither is heart disease. So, yeah, dive into everything you think about statins for us.
Yeah, unfortunately, statins have been vilified a lot, and I think they're probably the one of the top medications prescribed in the United States, if not the planet, right? Just because so many people have heart disease and or at risk for heart disease. So, with any drug, there's always baggage with any drug, right? To say any drug doesn't have a side effect or an adverse event, would be lying. I think the newer drugs that are coming out are having less and less off-target effects, more on-target effects. But when I was a fellow, before, while I was in cardiology training in Rhode Island, uh, it was during the time where the 4S study came out. That was the first landmark study in Scandinavians that used it, simvastatin, that showed an impact in patients that have had heart attacks, in terms of their survival. Before then, it was really unclear if statins increased mortality, cancer mortality, homicide, suicide. There was all this noise out there. This was the first landmark study that showed this in 1994. I remember it well because I presented it at our journal club. And then after that, there have been many studies in the secondary prevention space and in the primary prevention space. Secondary meaning you already have heart disease, and now we're treating you in primary. You don't have heart disease, but you're at risk for it. And so it's been well validated with multiple molecules over hundreds of thousands of patient years. So they're cheap, they're safe. They shouldn't be put in the water, in my opinion. I think it's any drug, and there's always impacts there. But I think they're a really good tool in our toolbox. Now, do they have side effects? Sure. And I think a lot of those side effects. Well, first, I want to say that the benefit, right? We have clear benefit in terms of cardiovascular and total mortality. We reduce the risk of heart attacks. They also have what we call pleiotropic effects. So it's not just about lowering cholesterol, it's about changing the biology of the disease. It reduces plaque inflammation, stabilizes soft plaque. So a lot of things in the blood vessels that they have benefit for. Now, like in America, if a little is good, a lot is better. And that's kind of where everything went. And so with that, all the trials have used maximum dose, high intensity statin therapy. And with those high doses, you get side effects. You get joint muscle aches, you can get diabetes, you can sometimes get cognitive dysfunction. Um, and in my opinion, in stable outpatients, you don't need to use the highest dose. There are a lot of paradigms in medicine where you use lower doses of combination therapies to maximize efficacy and to minimize adverse effects. And so I believe the time has come now in cholesterol heart disease management where we can do that. So I use lower doses of statins to achieve a certain percentage of cholesterol reduction, but then also knowing that I'm also changing the biology and I'm also minimizing their side effects. And then when I retest them and follow up, then if I am not at the goal that I want to be, then I'll add another agent. And we have a lot of tools in our toolbox to do that. So I do think the adverse events are often dose related. Diabetes, typically we see in 3 to 5% of folks, or increased blood sugar. And usually those are people that are already at risk, and it just expresses itself or accelerates the expression of that earlier. The whole issue of dementia, though, I would love to bust that myth. And so, unfortunately, like in a lot of epidemiological studies, there are a lot of variables and associations. And so a lot of people that we treat have heart disease, have diabetes, and have dementia, because dementia is associated with all these things. And they're on statins. And so there has been this causal relationship sort of hypothesized, but it's really not causal. And everything that I've looked at, I can't see. I've had a handful of patients on statins that get transient cognitive dysfunction, that get brain fog, and then either you cut the dose or you stop it and it goes away completely. So, I've had to find alternative therapies, but in terms of cause of dementia, I have not seen that. So I do think statins are, they lower LDL, they stabilize plaque, and they reduce inflammation. So I think they're the first line therapy in my mind, at least, in 2025. But we do have other therapies for those that can't tolerate statins, or you need additional cholesterol lowering. My go-tos are a drug called Zetia or ezetimibe, which binds to cholesterol in the gut, so to speak, and can result in a 20-25% reduction. It works really well, has a really neutral side effect profile, really well tolerated. And so that's often my first go-to. It's generic, it's cheap, it works really well with statins. I
Does it
don't.
have the benefits of stabilizing plaques?
Not that I know of, but now we do know that it does reduce risk of heart attacks. It has cardiovascular mortality benefit, but I don't know if that's just getting the LDL really low, but we don't know if it has plaque stabilization benefits. But there's another class of drugs called PCSK9 inhibitors. And Repatha, probably the most well-known and most marketed, and the other one, Praluent. And so these are injectable medicines. And so if we think about, let's think about the liver, right? So the liver makes cholesterol, and if it doesn't, and statins reduce the production of cholesterol in the liver, so the liver says, I need more cholesterol, so I'm going to put out more receptors, LDL receptors on the cell surface to extract more cholesterol from the blood. So that's kind of how that cholesterol drops in the blood. Um, Zetia or ezetimibe binds to cholesterol in the gut, and same kind of thing, the liver tries to figure out how to extract more LDL receptors. In biology, there's always there's always a counterbalance, checks and balances going on. So there's a protein called PCSK9 on the liver cell that can bind to the LDL receptor and inactivate it. And so then you have less LDL receptors on the liver extracting cholesterol. So Repatha and Praluent are a monoclonal antibody that basically inactivate this protein PCSK9. And so as a result, you have more LDL receptors, and you can dramatically reduce LDL by 50 or 60%. So that's a really cool. And so the cardiovascular event reduction data is really cool. The plaque regression data is really intriguing. So I think it's a really important tool in our toolbox. And by the way, it lowers LP little a, remember that genetic marker that we talked about, by 25-30%. Now, the FDA hasn't approved it for that indication, but as I think about, what tool to pick, if someone has elevated LP little a, yeah, that might go to that first, if insurance is going to cover it. And of course, that's always a part of the equation as well. And then the last drug that I think about is another injectable, which is really exciting, called inclisiran or Leqvio. And it's a twice-a-year injection, both under the skin, very easy. And it works by, it's a very cool bioengineering. It prevents production of this protein PCSK9 by altering mRNA expression. So as a result, PCSK9 is not produced, and it doesn't affect DNA, it doesn't affect anything like that, but it just prevents translation of this protein. And so same intention, target is to increase LDL receptors on the liver cell. So very similar magnitude of LDL reduction, well tolerated. Both of these drugs are extremely well tolerated, and it also lowers LP little a. So those are the tools that I have. And there's what's also exciting in the next year is drugs that can obliterate LP little a, so that genetic marker. So there are several molecules that have shown great promise, but we're waiting for the cardiovascular outcome trials this summer, this fall. And then I think the companies will submit to the FDA, for expedited approval. Now, how that plays with all the drugs and what that dance is going to look like and how you choreograph these drugs, I don't know yet, but it's exciting.
That is exciting. Why do you think statins got such a bad reputation? And also wondering what, taking CoQ10 to help with the potential mitochondrial effects of statins.
Yeah.
What might you natural supplements or other things might you pair with it to kind of combat that? But yeah, like how did statins get such a bad rap? Is there any foundation to it?
Well, I think what I said earlier, being one of the top drugs prescribed in the United States, people are going to get side effects, and the biggest thing that people get are muscle and joint aches. And the studies show 5 to 20%. It's probably higher than that, probably at higher doses. So I think because of that, and there's a lot of people that have arthritis and whatnot. So I think whenever you have a drug that's so widely prescribed, you're going to get noise around that, and people are going to have problems. And no drug is without baggage, and some people are going to experience bad side effects for whatever reason. So I think that's the genesis of all that outrage or the statin hating. Um, Partly too, people just don't want to take a medicine necessarily to lower their cholesterol if they can, and I get that. I 100% get that. So if you do have side effects, or you want to be proactive and preemptive about preventing a side effect, what do? So two things: I optimize their vitamin D. I make sure their vitamin D levels are okay, and I use the lowest doses that I can, and then I'll add CoQ10. Sometimes I'll have a discussion. So CoQ10 is naturally occurring antioxidant in mitochondria. It's depleted by statins, and anecdotally, they've done some studies to look to see if CoQ10 repletion supplementation makes a difference or not. And there hasn't been any solid data around that. But anecdotally, in my experience, it's really helpful. And whether it's placebo or not, it doesn't really matter to me because it works. And I usually have people take 100 to 200 milligrams a day, and it seems to work.
That's awesome. Are there any other, nutrients that you want people? Because what I've seen is people, of course, they always want from someone in my position, they want a natural pill to take, and I haven't been able to find any natural substances that really lower cholesterol, lower LDL. There's research around omega-3s increasing HDL and berberine, but I just don't see big changes when I do lab work, to be honest.
Yeah.
But there is evidence that, at least I don't have human trials in it, that some of these natural things can reduce the inflammatory oxidized potential of the lipids. I don't know if you know much about, if you could speak to any of that, because what I tell people is it potentially might be able to lower the inflammatory and oxidized potential, but don't expect the supplements to lower your cholesterol. I don't know if you can speak to that.
So I think my general approach to supplements is if you can measure it, then you can manage it, right? And so if there's a way, the problem with supplements, as you know, is it depends on who makes it and what the science is around it, and there's a multi-billion-dollar industry around that. So if I'm going to go with a supplement, I want to make sure that I go to a reliable manufacturer, right? And there's several of them around for sure. That's number one. So you don't know what the active ingredient is always in what you're getting, and there are problems with prescription pharmaceuticals, particularly on the generic side, and we've seen problems there. But at least there's some regulation around it, where there isn't any regulation in the supplement space. So that's number one. But number two, if I'm going to pick a supplement, I'd love to say, okay, what am I trying to achieve with that, and can I measure it? And if I can't measure it, then it's hard to know, right? I mean, a lot of things that I do, I measure, whether it's blood pressure, cholesterol, or A1C, or something like that. But in the supplement space, it's very subjective. Do I feel better, and how do I know? Having said that, a lot of my patients, come to me on red yeast rice, berberine,
In there, yeah.
but I've not seen, like you, I've not seen any dramatic benefits one way or the other. I haven't seen anything negative per se, but I haven't seen anything dramatic. And so I don't know of any specific any anti-inflammatory or any antioxidant type of benefits that any of these things have. Like even people look at food, blueberry and pomegranate as these magic foods, or superfoods, I guess that's what people call it. And I still don't buy that. I think if you eat lots of colors and eat, then you're gonna get what you need.
It's
But
been
I'd
a
love to hear your perspective.
Oh, well, I mean, so honestly, I was about to say it's been a number of years since I used to just obsessively read research, and then, you get to working more and you don't get to do that. But so I'm trying to remember where I get this, but like citrus bioflavonoids, bergamot, berberin, those are lots of popular ones. And I'm trying to remember if it was more just like petri dish studies that showed potential, or if it was rat studies. But I don't know if I'm going to try to run more Cleveland Heart Labs with people on these natural supplements, because then I can measure the oxidized potential I'm a
Yeah.
little skeptical it would work, but there's also so many other variables. Their insulin sensitivity, their diet, their gut microbiome, other
Yes.
inflammation.
Yes.
But like if you ever get people who want to take supplements, check it out. Let me know what you find from the Cleveland Heart Lab. We can run a little
Yeah.
experiment.
Yeah. No, absolutely. It's an area that, like you said, I need time to kind of think through it and kind of figure that out. But
Yeah.
uh,
That's awesome. Are there any other myths that you would like to discuss to bust, common concepts that you run into that you want to?
100%. So one of them is that it is not dietary cholesterol that causes elevated blood cholesterol. And I think that's a common myth. So, the whole thing about eggs are good, eggs are bad, egg whites, eggs are good. And it doesn't, to me, maybe it's a question of calories in terms of egg whites versus whole eggs, but I think eggs as a source of protein is phenomenal, right? And so I don't think it's cholesterol. I think the whole red meat thing is interesting. And again, I think it's looking at all these nutritional studies. It's not necessarily about the meat, but it's what other habits and other confounding variables. Are these people eating hamburgers and French fries and other crappy things along with that? So, if someone eats a high quality piece of beef, grass fed, grass finished, all those things, or how that animal was raised, then I think that's a different perspective and story than just generally that meat is bad and has cholesterol. So I think that's number one. Number two, not all fat is bad. I think trans fat and some saturated fat is bad, but high fat foods. I think the whole idea of skim milk just doesn't make sense to me. So as I said, I'm a little bit lactose intolerant, so I don't drink much milk, but I do use full fat Greek yogurt, so I think that's okay. Um, what's the other myth? Is there any other myths? I think that's those are the big things for me.
Would you say differently for ApoE for four people or for three or yeah?
Yeah, so I think their sa- saturated fat probably is lower saturated fat probably is better for those people, and um, I'm not uh, I don't understand the biochemistry of that as well, to be able to
Couldn't put
comment
it. Yeah,
too
couldn't.
much detail.
I've just read that like there's these things in your brain, like my brain, they pull a file out and I'm like, I can't corroborate that, but I remember reading it. Um, so I mean, I wonder if it's eating meat or beef. Oh, what is the chemical that it's supposed to release that got a bad rap with heart disease? Do you know what I'm talking about? In the
EMAO.
yeah, in the gut. Yeah, yeah, yeah.
Yeah,
Can you,
yeah.
I don't know much. I can't quote that. Do you know much about that?
Yeah, I think there's a lot of noise around that too. I mean, because it can be related to fish, it can be related to other things. So I was checking TMAO, and I honestly don't understand it that well.
Well,
So I've stopped checking it.
yeah. I mean, the other thing, I think it's like an inverse of the French paradox. Like, alcohol used to be, or at least wine, associated with health benefits. And when you said social connection's a huge one, but
Yeah,
also, walking, also the quality of the rest of the diet. And so I think
yeah,
same thing with meat, it gets a bad rap because often a lot of processed foods, a lot of fast foods, there's a lot of meat. And so the meat gets associated with the effects of the fast food, and then vice versa, kind of inverse of the French paradox. If they're eating a grass-fed finished piece of beef, they're probably also eating a very whole foods, natural, nutrient, antioxidant rich diet. So it might be the meat is, again, more of a correlation than a causation, kind of like the
yeah,
Alzheimer's and statins. But yeah, do you think that's
yeah,
at all possible?
yeah. No, I do. I think there's a lot of noise in that space. So I think uh, the question is that's still TBD in my. There are a lot of people that are pushing protein and up to 1.5 grams per kilogram type of. I don't know what the right. I think we have to be careful about that. I think what the RDA recommends is woefully low, and so I think there's somewhere in the middle where, because then there's no way you can consume that much protein without taking a lot of protein powder, and they're not all protein powders are created equal. So
Yeah. I mean, with the protein, which is definitely one of the latest fads lately, for me,
mhm.
it's whether or not it's bad for you. To me, it's I think a lot of people do it to help with weight or as some sort of health benefit that I just do not think comes from eating gargantuan amounts of protein. Like all things being equal, if you increase your protein by 50 grams or 40 grams a day, are you going to lose weight? Maybe if it helps you with satiety or with blood sugar balance, but it's not the protein, it's the satiety and blood sugar balance, which you can do by eating plants, by getting better sleep.
Yeah.
But anyway, well, I'm waiting for that fad to pass.
Yes.
Yeah.
The other myth is, I hear a lot, and I see out there is that it's not about cholesterol. It's not about cholesterol. And I think the inflammation piece is really important, right? And both are true. So I think about cholesterol being the fuel, and inflammation is the match. So you light up, and without inflammation, bad things don't happen. But once you have inflammation, however you get it, then you're at risk for autoimmune and cancer and diabetes and heart disease. So I think cholesterol plays a role. It's not the only villain in the whole genesis of heart disease, but it's an important one. And without cholesterol, you're not going to get plaque. So
All the
um,
above. Yeah.
yeah,
I appreciate your time. Do you have time for one or two more quick questions to wrap up?
sure,
Okay.
yeah, yeah,
I love this. Thank you so much.
it's
10
fun.
years, 10 years from now, where do you think cardiology is going? And also, of course, what do you think of AI?
Oh wow, so heavy question.
Finish up question. Yeah.
I think, as we've talked a lot about trying to eradicate and obliterate atherosclerotic cardiovascular disease, plaque in the arteries, I think we can do it, right? And if we get cholesterol levels really low, we can do it. Now you could say, well, does that mean no one's going to have heart attacks or strokes? No, because the pipeline is very secure. At least in Virginia, it is. With lots of bad eating and all that. But I think what's exciting is that we can really change the biology of disease, and that's the way I think about it. Is like I'm not just treating numbers; I'm treating the disease. And if we can reverse disease, and that's sort of what I really show up to patients that, hey, we can reverse that soft plaque in your arteries and you can lead a nice normal life, whether you've had an event or you haven't had an event. We can do that if we work together on all these things, right? With all the pillars, right? So to me, that's really exciting. The other part from a therapeutic stuff, and in our practice, a lot of the things that we do, stents, devices, ablation of AFib, are shifting from the hospital side to the outpatient side, very much like our surgical colleagues, like orthopedics and ophthalmology and dermatology. So it's cheaper, it's a better experience, it's faster, and so we're already pioneering that in our practice in Richmond at James River Cardiology. So I really think the future of cardiology is also shifting from the hospital, where they're at sick care, to the outpatient side, which is more proactive and preventative type of care, and everything else in between. And obviously, our population is aging, and so with what comes with that is a lot of things that we need to take care of our folks, and that's kind of where I think AI is going to really help us, because there's no way that I can know everything that needs to be known at that point of care. So when I'm seeing that patient in the exam room, and I have their patient level variables that I need to sort out, and the science that's out there, and then to be able to look at all their data, like you were talking about earlier, is how do I look at all their numbers over the past 5 years or 10 years and make some predictions around that? And if I can use AI to help me in that moment come up with a better diagnostic and prescriptive plan for that patient, that would be amazing, and it will happen. I
Yeah.
think so. I think AI's predictive and therapeutic tool is going to play out, and it's not going to replace physicians, providers. It's going to augment them. I look at it as augmented intelligence. And I think the other way it's going to help us, it's already helping. me is on the documentation side, right? We live in a world where documentation is everything because that determines communication, your level of charge, your compliance, blah, blah, blah. And so if we can use AI to do natural language processing, take in the history from the patient, organize it in a way that can really help ease burnout issues, drive efficiency, and just make, physicians happier.
With
So I
better
think
results.
with better results, right? So I think there's opportunities there.
The Freakonomics just did a recent series. One of them was on supplements. One of them was on AI in medicine. If you like podcasts, it was pretty
Mhm.
recent. Yeah, yeah. You mentioned something, and I just want to check this out again. I'm selfishly have you here as much for myself as anything else. Um, so atherosclerotic inflammation, insulin resistance, cell membrane damage. These are also kind of is it not? Is it true that these are all natural parts of aging to different levels in different people? So all of the preventative wellness in the world and interventions, it is kind of just part of aging. Is that accurate at all?
Yeah, so senescence, aging is definitely, you could think about it as a process in itself. And a lot of people are trying to hack that. I don't know if it's hackable, but I think what we can do is I would love to say, hey, listen, let's really work on our quality of life or our health span, as people call it, and not so much on the longevity space, because I don't know if and when we can hack that, and not sure that any of us want to live to 130 or 200 years of age. But
Not
if
me.
we can live our best life for as long as we can, then fall off the cliff, then that's better, rather than what happens is that we go down the slippery slope and have this miserable last 6 months of our life. And if we can change that trajectory where we die in our sleep, that would be lovely. And so I think all the things that we're looking at around inflammation, particularly, is going to help us not only with heart, but cancer, neurodegenerative diseases, which is really afflicting so many people. And no point in living if you have no cognition or poor cognition. So um, I don't know what those answers are going to be. What are going to drive those? But I really, really feel like it's going back to basics, right? It's going to be, we talked about diet and lifestyle. We didn't talk about sleep very much, and that's a whole nother holy grail,
Yeah,
where the quality of sleep makes such a big difference because it's restorative. And people that we know that people have sleep apnea have a lot of cortisol and fight or flight, and they have hypertension and at risk for heart failure and dementia and
makes sense.
whatnot. So
Yeah.
I think really optimizing sleep, and I know there's a lot of stuff going around trying to hack that. However, we get good quality deep sleep and REM sleep is going to be important. And the other piece here is so sorting out stress. And I think we live in a very stressful age, a period of time for lots of reasons. And I look at stress as not so much what the external stress is, but how we as humans cope with the stress. What are our stress mechanisms? And that the activation of your fight and flight or fight or flight is going to, how much we have control over that is going to really influence inflammation, right? Because as hunter gatherers, again, going back to that, we would be chased by the saber-toothed tiger and our adrenaline would go up. We'd shunt flow to our muscles, and we would find safety. And as soon as we found safety, everything came back to homeostasis. But in today's world, our stress hormones are cortisol, adrenaline, everything are all jacked up and they just kind of stay that way. So that to me is going to be the ultimate hack is that's a cause of inflammation, right? And or one cause of inflammation. And so if we can adapt our stress response, whether it's breath work or exercise or connectivity or meditation, mindfulness, all these things, I think will really help us going forward.
Well, that's perfect. That's actually a really good summary of kind of all of this in preventative cardiology, probably preventative medicine as a whole, in health optimization is um, cardiovascular, or excuse me, fitness, exercise, nutrition, sleep, mindfulness, meditation. I know a lot of us are preaching that. And then if that isn't doing everything for you, or then there's a personalized, targeted pharmaceutical therapies based on a multitude of lab markers and imaging to determine your risk factor with brilliant cardiologists like yourself.
No, I'm excited. I'm a late career cardiologist, but I've got a lot of energy and enthusiasm, and I'm excited about how I can make impact on my patients, moving forward, more broadly speaking to the things that you're doing in your practice, which is really exciting. And so I hope that we can continue to collaborate.
Oh, that's such an honor. I so appreciate being able to work with you and trust that our people are being taken care of, not just medically, but as human beings too.
Yeah.
So I really appreciate it. Yeah. Okay, so last, and then I will let you go. I really so value all your time. Where do you see yourself in the next with cardiology going? I know you have other businesses and other interests and so forth. Like, what's the future of Dr. Kapadia?
So the things that I'm really interested now, beyond taking care of folks and really the science of cardiovascular disease and health and wellness, is sort of my one is elevating patient experience, and in medicine in general, that generally is fairly mediocre, right? And so at every level, and there's these islands of excellence, but most of it kind of, I hate to say it, but you just have to suck less to do better. And that's kind of the mantra people have, and the expectation, right? The bar, patients have very low bar, and sometimes we can't even meet that. And so to me, a big part of what I'm doing within my practice at James River Cardiology is really focusing on elevating patient experience, and not necessarily, we're not trying to be the Ritz-Carlton or anything like that, but it's just taking care of people, right? When they come in, looking and smiling at them, acknowledging that they're human, that they're there. Patients come into our space not because they're excited to, but because they've got a problem typically. And so, they can be grumpy, they can be mad, they could be angry, they could be all these things. And we have to understand that. And as they flow through their journey of check in and check out and seeing the physician and going home and all of those things, that if we can make that, number one, less more frictionless, but we can do it with a lot of empathy and compassion and be present, I think that's something that's really top of mind for me. um, and I'm trying to build that culture within our practice. And number two is to teach our young physicians, providers that are coming through, they come in with the skill sets and the knowledge, but they don't necessarily know, not all of them know how to connect, right? And when you have 15, 20 minutes sometimes to see someone, how do you go in and connect in that moment, build trust, and then deliver hope, is sort of what I want to pass on and mentor, these younger providers going forward. So those are my interests in the next decade.
That's awesome, and that's a perfect reflection of you, who I've had the honor to get to know, and hard to get into the medical system, and we need so much more of that. So thank you. Yeah,
Yeah.
yeah. Any
Well,
other
thank you so
final?
much.
Yeah, thank you. Any other final takeaways you want people to hear?
No, I think we've covered it all.
Yeah, this is awesome. This is kind of like, mini cardiology tutorial for everyone. This is exactly what I wanted. I'm so grateful. Thanks
Oh,
so much,
good.
Dr. Kapadia.
I
Yeah.
had so much fun. Thank you,
Oh,
Tressa.
thank you. I will talk to you out there. Have a
Okay.
wonderful weekend. Oh, you know what?
What's that?
Quick shout out to your daughter. How's she doing?
Oh, yeah. So she
Following in your steps, UVA Medical School.
Well, so she's at Brown Medical School and
Hmm,
she's graduating in May.
that's
She's
right.
going to do internal medicine, and we'll
She's
see where she ends up after that. She's really interested in women's health. And so however she falls, she will find her path and her journey, because her empathy level and
yes.
ability to connect is next level for me. So
Yeah. Well, your family's, I mean, she gets it. It's great. Yeah. God, graduating. I remember when she got in,
I
going,
know.
"Oh, how did that happen? We're not any older." Yeah.
Yeah, I
Well,
told her I was talking to you today. She said to say hi, and she was very
oh, that's
excited.
so kind. Yeah, no, I think about her. Well, congratulations to her. Thank you so much for so much of your valuable time. I really, really appreciate it. And so will everyone who gets to hear this.
Thanks a lot, Tressa.
Thank you, Dr.
Take care.
Kapadia. Take care.
Bye bye.